My topic today is cutting and scoring balloon technical tips and tricks. So we heard earlier two speakers telling about how to manage in calcified lesions. So they talked about IVL, IVL and rotablation. So my topic today is more of cutting and scoring balloons. So the block modification is needed in fibrotic lesions, calcified lesion, and in-stent renosis. And the specialty balloons available are a cutting balloon, a scoring balloon, and a high-pressure balloon. IVAS and OCT are very useful to understand whether it is a fibrotic lesion or a calcified lesion or a regular non-calcified, non-fibrotic lesion. If a non-calcified, non-fibrotic lesion, you do a pre-dilatation balloon, you stent, you get a very good result. It is a fibrotic lesion, you use either a cutting balloon or any other device and a scoring balloon, then you get a good stent result. If it's a calcified lesion and as the score with the OCT or an IVAS shows that it's more than 2 and 4, you do either rotational atherectomy or an IVL. So in a fibrotic plaque, it's a very rich in collagen or muscle cells. A standard balloon, it's a high recoil and unsatisfactory lesion preparation, and there's a high risk of slippage in this fibrotic lesion. The impact of calcium, as earlier speaker told, the increased risk of MACE at 1 year with moderate to severe coronary calcium. There is a suboptimal stent expansion, increased stent restenosis, increased stent thrombosis, and device delivery failure can also occur, and increased procedural time. So you wanted a good preparation, especially you wanted a good preparation with the calcium in these cases, so optimal stent deployment. And then if you want a good long-term result, you should modify the calcium. Earlier speaker has told about the rule of 5 with an OCT, and we have an IVAS score when OCT is not available, not affordable. You can use the IVAS score also. And as the earlier speaker has said, the OCT score, if it's more than 0.5 millimeter and arc of calcium is more than 180 and calcium length is more than 5, these people need a more calcified modification like with IVL or ROTA. And IVAS score again, if circumferential calcium is more than 360, length of calcium is more than 5, the diameter calcium is less than 3.5 and calcified nodule is present, again these patients need again a modification with IVL or rotablation. The treatment option for calcified lesions, the balloon-based lesions, which forms a cracks in the calcium leading to increased plaque elasticity, and you can use a non-compliant balloon, you can use a cutting balloon, scoring balloon, high-pressure balloon, and intravascular lithotripsy. Ablation techniques, they ablate the plaque with a differential cutting and sanding. Not much effect on deep calcium. We have rotational atherectomy. Orbital atherectomy is not available in the country. XML label is available, and we have good experience with XML label in this some of the uncrossable lesions. Coming to the cutting balloon, it has 3 to 4 atheratomes, microsurgical blades longitudinally, and a semi-compliant and non-compliant balloon. They are radially directed, longitudinal cuts to expand vessel while limiting controlled dissection. The pressure preferentially distributes on the blade. The earlier flexotome was more bulky, it was a difficulty to cross lesion, but now the Wolverine atherotome, they have reduced the functional height, that's why it is better crossable when compared to the old flexotome. Coming to the sizing of cutting balloon, they are selecting the diameter, the balloon to artery ratio should not exceed 1.1 to 1 in vessels more than 3 millimeters. For vessels less than 3 millimeters, it should be not 1:1 as more appropriate. But if you are using an IVAS, measure the media to media and maintain 1:1 balloon ratio. The COPS trial has shown the cutting balloon to optimize pre-dilatation before stenting. The final MSA at calcium site is better and minimal stent diameter at calcium site is better when the cutting balloon was used. So especially the benefit of cutting balloon was more in lesions with more than 270 degrees out of calcium. The second balloon which is available for us in India is scoring balloon, angiosculpt. It has 2 component system, conventional semi-compliant balloon angioplasty catheter and nitinol scoring element, which is laser cut and electropolished. There are 3 nitinol spiraling scoring elements on this balloon, and this nitinol enhances inflation and deflation and excellent rewrap and recross abilities. The controlled concentrated radial force helps to make the plaque more amenable to remodeling as the balloon is inflated. The angiosculpt, the mechanism of action is precision, power and safety. The precision, the heads lock in So minimal slippage, rectangular scoring edges lock the device in places. No significant device slippage or watermelon seeding means less risky to damage to healthy tissue. And there's a more dilatation power, there's a more dilatation force, the power is there. The leading edges are designed to drive forward expansion up to 15 to 25 times the force of a conventional balloon. Angiosculp helical nitinol element creates a uniform nitinol luminal enlargement also. Coming to the safety, low dissection rate, post-scoring outward forces are designated to be equal to that of conventional balloon, low dissection rate and minimal perforations, low rate of adjunctive stenting, and zero or flow limiting dissections are very less. So these are the three main mechanisms of action of angiosculp. This is angiosculp compliance chart which we can use. The differences between cutting and scoring balloon, the scoring balloon is different from cutting balloon, is less non-compliant, and at high pressure its diameter tends to increase. And the profile of scoring balloon is slightly better than cutting, especially in a tortuous lesion. The scoring balloon can reach the tortuous lesions. And the cutting balloon provides 3 to 4 longitudinal cuts along the vessel lumen, and the angiosculp provides 360 degrees of uniform scoring. So when you wanted 360 degree of uniform scoring with a cutting balloon, what we can do, we can take back the cutting balloon into the guiding catheter, rotate it, and then go and cut it. So we'll get more uniform cutting with the cutting balloon. The other balloon is available is Orbachny Scoreflex, and this is effective focus force relation with dural viral system. X-flex tip and trifold folding will help in low profile crossing profile. We don't have much experience. The other balloon is available is a grip balloon. This is a puncture resistant NC balloon with 4 rows of knobs, total 16 knobs to ensure stability, prevents balloon slippage and crack, block and crush calcified lesions. It prevents slippage and watermelon effect. Indication, ostial lesion, bifurcation lesion, instant restenosis, highly fibrotic lesion and calcified lesions. And it's available in India, and the cost is much less than the scoring balloon and the cutting balloon. So it's a more cost favorable balloon. The other balloon which is available, a high pressure OPN balloon, and the balloon specification non-compliant material. A linear compliance curve up to 40 atmospheres. It a double layer balloon with minimum dog boarding effect. Normal is 10 atmosphere, rapid rated burst pressure is 35 atmosphere. It's a super high pressure OPTCA balloon, and the mechanism of action is non-cutting and non-scoring. Coming to the recent study just published in November, this is what the new study has shown. The rota-cut combination resulted in a higher instant luminal gain and larger minimum stent area compared with historical control of a rota-category or a modified balloon, but was not associated with higher stent expansion. So rota with a cutting balloon increased luminal gain compared to rota alone or balloon modification alone. At 9 months, the clinically indicated TVR was 2.7% and TLR is 6.3 with a rota cut. So with this, I just want to share one of the cases we did in our hospital with our team. So this is a patient with acute coronary syndrome, NSTEMI, evolved inferior wall MI, and coronary patient was in cardiogenic shock and moderate LV dysfunction, moderate MR, and non-diabetic and non-hypertensive. And angiogram was done, showed a distal left main triple disease and calcified triple vessel disease. The patient was referred for a coronary artery bypass surgery, and the surgeon was not willing to do because the patient was short stature and the risk was high because of the presence of moderate MR. So patient initial attempt for an angioplasty vagina, which was not successful. So this is an angiogram. So we planned the angiogram. We have used a power backup guiding with a long sheet support. And this is an angiogram. You can see the distal left main critical, and you can see the long segment LED lesion. And you can see there's a heavy calcium in the ostium of circumflex also. So we initially crossed the lesion with a cyan blue balloon, and we exchanged the cyan blue balloon with a microcatheter, and then we did use microcatheter, and with the microcatheter we used a rota floppy wire, and we did a rota ablation with 1.5 millimeter burr. And this is a burr, and this is an OCT which shows that after bulling there is the wire bias which was there, and which and you can see the rota cut. There is a calcium crack, and you can see dissection with the thrombus there, and calcium nodule post crack you can see at the post rota. And we did more rota in this IV OCT to get the differential distal reference diameter, which is 2.5, and the proximal reference diameter was 3 millimeters and left main was 4 millimeters. So then the lesion was prepared with an NC balloon and a cutting balloon, and after we got a good balloon expandation, the distal LED was tented with 2.5 into 38 millimeters balloon. And after getting digital LED, we did a rota again to the ostial circumflex, and you can see how the rota was difficult it was. And this again we did 1.5 millimeter balloon, and here again we used a cutting balloon and IVL balloon to get a good adequate expansion of the balloon. And once we are comfortable that we got a good adequate the balloon is adequately expanded, we did a decay crush there, and these are the various steps, and this is the final result of the decay crush. So special balloon indication, cutting balloon is useful in calcified lesions, and the scoring balloon also used in calcified lesions, and OPN balloons are used in calcified lesions. Calcific nodules, cutting balloon doesn't have much role, and scoring balloons must have role, and OPN balloons are not useful. Fibrotic lesions, cutting balloon is better than scoring balloon. OPN balloon doesn't have much role. Stunt under expansion, cutting balloon is useful, but OPN is much useful in this case. Instant restenosis, you can use a cutting balloon and scoring balloon, and OPN balloon also we can use, but cutting balloon and scoring balloon are much better in this situation. This is a small calcium algorithm again, which has been already told. So whenever the balloon crossable lesion, if it's superficial and the score is less than 1 to 3 in OCT and less than 2, you can use a NC balloon and a cutting balloon or a scoring balloon. And if the OCT score is more than 4 and IVSC score is more than 2 and calcific arc is more than 270, you have to use either a ablation or a orbital atherectomy. And if you have eccentric calcium and wire bias, and you can use an IVL here. And if the fracture is good and minimal luminal area is less, again you use a cutting balloon and NCN balloon and scoring balloon. Once you get a good balloon expansion in 2 orthogonal views, you good MLA you get, deploy the stent, and post stent expansion. If still you are not happy, you can use open NC and IVL balloon. Take home message, special balloons, various options are available. Use of imaging must for adequate size to decrease the risk of perforation. Combination of different therapies and effective strategy for adequate stent expansion. Thank you very much.